स्टूडेंट्स का कुछ जो आवाज वगैरह अच्छी थी तो स्टूडेंट्स आने अच्छे थे और ये था अनमिट थे जिस पीपीटी आवाज होती थी
अस्सलाम वालेकुम बेटा। Beta, our today's topic is the liens of RBCs. We are starting the chapter, new chapter, blood disorders, the liens of RBCs, and the topic is anemia. Anemia. आवाज आ रही है ना बेटा?
Yes, ma'am.
Bismillahirrahmanirrahim. By definition, the anemia is defined as hemoglobin below 2 standard deviations of the means for the age and gender of patient. Classification of anemia. Number 1, blood loss. Blood loss could be acute due to trauma or surgical or obstetrical procedures or loss. And second one is the chronic loss, either gastrointestinal lesions or gynecological disturbances. Second thing is increased red cell destruction due to number 1, inherited genetic defects, the red cell membrane disorders. Examples are hereditary spherocytosis and hereditary elliptocytosis. Second thing is red cell enzyme deficiencies. Number 1, G6PD or glucose 6-phosphate dehydrogenase deficiency or glutathione synthetase deficiency, as well as pyruvate kinase deficiency. Third thing is hemoglobin abnormalities. Number 1, the first thing is deficient globin synthesis or quantitative defects of globin. Example is thalassemia syndrome. And second thing is hemoglobinopathies. Here is qualitative defect of hemoglobin. And the example is sickle cell disease. Another thing is here is acquired genetic defects. Deficiency of phosphatidylиnositol-linked glycoproteins. Example is paroxysmal nocturnal hemoglobinuria. Third thing is antibody-mediated destruction of red cells. Hemolytic diseases of newborn, RH disease, transfusion reaction, which is also antibody-mediated, and drug-induced autoimmune disorders. Fourth one is the mechanical trauma to the RBCs. There is microangiopathic hemolytic anemias due to hemolytic uremic syndrome, disseminated intravascular coagulation, thrombotic thrombocytopenic purpura. Cardiac trauma, which causes hemolysis, are defective cardiac valves. Repetitive physical trauma, bongo drumming, marathon running, and karate chopping. These all are responsible for the hemolysis of RBCs. Infections of red cells like malaria, babesiosis, toxoplasmosis.
मैं तो देख रही हूँ इतनी देर हो गई.
Clostridial sepsis, snake venom, and lead poisoning. These all are also responsible for RBC's hemolysis. membrane lipid abnormalities, A beta lipoproteinemia, and severe liver disease. Another cause is sequestration, hypersplenism. Now, decreased red cell production. Number one, inherited genetic defects, stem cell depletion defects in Fanconi's anemia, erythroblast maturation defects in thalassemia syndrome. Nutritional deficiencies are also responsible for decreased red cell production. Example are DNA synthesis in vitamin B12 and folate deficiencies, hemoglobin synthesis in iron deficiency anemia, erythropoietin deficiency in aplastic anemia and pure red cell dysplasia, immune-mediated injury of progenitors, red cell progenitors in aplastic anemia, inflammation-mediated iron sequestration, anemia of chronic disease, primary hematopoietic neoplasm, acute leukemias, space-occupying marrow lesions, metastatic or granulomatous lesions. Classification of anemia on the basis of morphology. Number one, microcytic hypochromic anemias. Here the MCHC, mean corpuscular hemoglobin concentration, and mean corpuscular volume, both are low. Examples are iron deficiency anemia, thalassemia, and anemia of chronic disease. Second one is normocytic normochromic anemias. Both MCHC and MCV are normal here, and examples are anemias of chronic disease, hemolytic anemias, anemia of acute hemorrhage or acute loss, aplastic anemia. Third type is necrocytic anemia, normal MCHC and high MCV due to the deficiency of vitamin B12 and folic acid. This is the morphology of RBCs. First picture, this one is, as you know, the 7 micrometer is the normal diameter of RBC. This one is the macrocytic RBC. When we are comparing both, this one is larger in size, this is macrocytic. This one is microcytic, hypochromic. This one is a spherocyte. This one is stomatocyte, electrocyte, and schistocytes. सबसे पहले iron deficiency anemia. It is the most common cause of anemia worldwide. It results in microcytic hypochromic red cells on the peripherals where the cause of iron deficiency anemia, it is varies based on the age, gender, and socio-economic status. Deficiency of iron is due to the insufficient iron intake, decreased absorption, or blood loss. Low dietary intake, increased systemic requirement like pregnancy, adolescence, or growing age, and a decreased absorption such as in celiac disease. In neonate, breastfeeding is protective as it is iron is present in the breast milk, but the deficiency is most common form of iron deficiency anemia is the most common form of anemia in young children on cow's milk. Parasitic infestation is also a significant cause of iron deficiency anemia. And the dietary sources of iron are green vegetables, red meat, and iron fortified milk. Etiology: acute and chronic blood loss, trauma, GIT loss, gynecological or obstetrical loss, increased requirement in adolescents, pregnancy, lactation, growing age, nutritional deficiencies, most commonly in the poor socio-economic group, multiparity, and decreased absorption as GIT pathology and use of drugs. Pathophysiology: iron is essential for the production of hemoglobin, and the depletion of iron stores may result either from blood loss or decreased intake or impaired absorption or increased demand. All may be responsible for deficiency of iron. Iron deficiency anemia could arise from occult gastrointestinal bleeding for prolonged time. Adults older than 50 years of age with iron deficiency anemia and GI bleeding need to be evaluated for malignancy. This iron deficiency will lead to microcytic and hypochromic anemia on the peripheral smear. Clinical features: easy fatigability, loss of energy with exercise, shortness of breath and headache with exercise, difficulty in concentrating, dizziness, pale skin, leg cramps, insomnia, brittle nails, koilonychia or spoon-shaped nails. Volume बंद करो। Atrophy of papilla of the tongue, angular stomatitis, brittle hairs, dysphagia, glossitis, and Plummer-Vinson or Patterson-Kelly syndrome. How to diagnose iron deficiency anemia? Complete blood count. This shows low mean corpuscular volume (MCV) and low mean corpuscular hemoglobin concentration (MCHC). On peripheral blood smear, microcytic and hypochromic RBCs with marked anisopoikilocytosis in chronic cases, anisocytosis and poikilocytosis. Platelets increased usually. Then serum iron, total iron binding capacity and serum ferritin. Serum iron is low. Ferritin levels with an elevated total iron binding capacity should be evaluated. Total iron binding capacity are diagnostic for iron deficiency anemia. These are the normal references ranges for red cells indices. MCV expressed in femtoliter, MCH expressed in picogram, MCHC expressed in grams per deciliter. These all are the normal values. This one is a microscopic picture of the blood. You can see the RBC's shape is not equal. There is variation in the size as well as shape of the RBCs. Microcytic lakes the central pillar. Hypochromic, small size, and microcytic means small size. Hypochromia means lack of central pillar. Marked anisocytosis and poikilocytosis. Now hemolytic anemias. Hemolysis, it could be extravascular or intravascular. In extravascular hemolysis, there is premature destruction of the red cells within the phagocytes, which is caused by the alteration that render the red cell less deformable. There is anemia, splenomegaly, and jaundice, main clinical features of extravascular hemolysis. In intravascular hemolysis, due to either mechanical injury or the complement fixation or intracellular parasites, exogenous toxins, they may cause hemolysis within the vascular system. The clinical features are anemia, hemoglobinemia, hemoglobinuria, hemosideruria, and jaundice. Hemolysis due to red cell membrane disorders. Hereditary spherocytosis. It is an autosomal dominant defect which is caused by intrinsic defect in the red cell membrane skeleton and leading to the spheroid, less deformable red cells that are vulnerable to splenic sequestration and destruction, resulting in extravascular hemolysis. The pathogenesis here is a variety of molecular defects in the genes that code for the red cell proteins. These proteins are necessary to maintain the normal shape of RBCs, and the defect is due to insufficiency of the membrane skeleton component of the red cells. The mutations here affecting the ankyrin which is most commonly involved. The second one is the band 3 spectrin or band 4.2. These are all the components of red cell membrane. The deficiency of membrane skeleton reduces the stability of lipid layer, leading to loss of membrane fragments of RBCs. In circulation, this defect leads to the decreased surface to volume ratio that results in the spherical shaped cells. These are less deformable and unable to pass through the fenestration in the splenic red cells. So, hemolysis takes place because of the splenic trapping of these red cells. Clinical presentation: anemia, splenomegaly, jaundice. In heterozygotes HS present at birth with marked jaundice. In 20 to 30% of the patients, mild disease or asymptomatic. Aplastic crisis may occur and triggered by parvovirus infection. This parvovirus infect and kill the red cell progenitors. So, there is decreased red cell production and worsening of anemia. Hemolytic crisis may occur with infectious mononucleosis infection and increased splenic destruction of the red cells. Laboratory diagnosis: complete blood picture. There is spherocytes. Red cells are spherical or spheroids. These are small and make the central pillar. So these are spherocytosis there. There is reticulocytosis. MCHC is increased. In bone marrow, there is marrow hyperplasia, mild jaundice, Coombs test. Coombs test is negative here, and the osmotic fragility test, which is done for the diagnosis of spherocytosis, is positive. Here in this osmotic fragility test, the rupture of spherocytes occur in hypotonic solution due to the influx of the inside the red cell. This hypotonic solution is entered into the red cells and then causing the lysis of red cells. This is the diagnostic for spherocytosis. Spherocytes, these are abnormally small. These are hyperchromic. Makes the central pillar. Now the thalassemia syndrome, hemoglobinopathies. By definition, these thalassemia syndromes are a heterogeneous group of disorders caused by inherited mutations that decreases the synthesis of hemoglobin. Adult hemoglobin A. Types of thalassemia: alpha and beta thalassemia. Beta thalassemia is characterized by diminished synthesis of beta globin chain with relative excess of alpha chain. These alpha chain damages the red blood cell precursors and red blood cells. Resulting in abuse. Classification of thalassemia: beta thalassemia 0 or absent globin chain synthesis, and beta thalassemia plus there is reduced quantity of beta globin chain synthesis. Molecular pathogenesis: here it is mostly point mutations are involved in the thalassemia. The splicing mutations are the common type of point mutation, which involves the introns, exons, RNA splice junction destruction. Promoter region mutation: 70 to 80% reduction in the transcription by mutations, resulting in the synthesis of some of the normal beta globin synthesis. Chain terminator mutation, most common cause of beta thalassemia. There is creation of stop codon within an exon. And the second one is the small insertion or deletions that shift the messenger RNA reading frames. This is a molecular pathogenesis. These both block the translation and prevent the synthesis of functional beta globin. The deficient hemoglobin A or adult hemoglobin result in the hypochromic microcytic red cells with subnormal oxygen transport capacity. Diminished red cell and precursor survival due to the imbalance from alpha and beta globin synthesis. The unpaired alpha gene precipitates within the red cells, and these inclusions damages the red cell membranes and leading to the apoptosis or cell death of 70 to 80% of the affected red cells. Then splenic sequestration also causes extravascular hemolysis. Types of beta thalassemia. Beta thalassemia major, intermediate, and minor. Major one is the post-mortem. The clinical features are here anemia due to reduced hemoglobin synthesis. There is extensive extramedullary hematopoiesis, splenomegaly, skeletal abnormalities, extraosseous mass protection in the thorax, abdomen, and pelvis. There is severe cachexia. Iron overload due to the iron transfusion and iron therapy causing injury to the liver, pancreas, and secondary hemochromatosis. Beta thalassemia major is also called Cooley's anemia, and the types are B0 and B plus. In B0 there is zero formation of hemoglobin. Laboratory and clinical findings. Peripheral blood smear. RBCs are anisocytosis. There is marked variation in the site is called as anisocytosis, and then there is marked variation in the shape of RBCs. It is called as coagulocytosis. Target cells, where hemoglobin collects in the center of the cell. Another feature is basophilic restricting of the red cells. There is reticulocytosis. Normoblasts are also seen. These are poorly hemoglobinized red cells, precursors to stress erythropoiesis. These are target cells. Bone marrow and spleen. Marrow expansion at the face and skull, erosion of the bone by marrow, and the formation of new bone. Creeped appearance on the X-ray film. Phagocytic hyperplasia, extracellular hematopoiesis, leading to splenomegaly. Spleen may be up to 1500 milligrams in weight. X-ray findings creeped appearance on the X-ray skull. But for the exact diagnosis, hemoglobin electrophoresis is best. Hemoglobin A is absent. Hemoglobin A2 is normal or high or low. There's variation. But hemoglobin F, fetal hemoglobin, is markedly increased. Alpha thalassemia. It is an autosomal recessive disorder and it is characterized by decreased synthesis of alpha globin gene with relative excess of beta gene. Clinical symptoms. Silent carrier state, number 1. This condition is characterized by this condition is associated with single globin gene deletion, and the patient is clinically and hematologically asymptomatic, or there may be slight microcytosis, nothing else. This is carrier state. Alpha thalassemia trait. It is caused by deletion of 2 alpha globin genes deficiency from a single chromosome, or there is deletion of single alpha globin gene from each of 2 chromosomes. There is microcytosis, minimal or no anemia, no abnormal physical signs. Hemoglobin A2 level are normal to low. Third form of alpha thalassemia is hemoglobin H disease. There is deletion of 3 alpha globin genes Deletions of three alpha globin genes, which are responsible for hemoglobin H disease. This is common in Asia. With only one normal gene, the synthesis of alpha chain is markedly reduced, and the tetramers of beta globin, called hemoglobin H, forms. There is moderately severe anemia. Fourth form is hydroxyfetalis, most severe form, and it is caused by deletion of all four globin genes, and it is characterized by precipitation of gamma chain tetramers, the hemoglobin parts. The signs of fetal distress become evident even in the third trimester during pregnancy. Another anemia due to the red cell enzyme defects, glucose 6-phosphate dehydrogenase deficiency. It is a recessive X-linked inheritance pattern. Only males are affected here, and the pathogenesis here is the abnormalities in the hexose monophosphate shunt or glutathione metabolism, and this results from the deficient or impaired enzyme function. Reduces the ability of red cells to protect against oxidative injury, leading to hemolysis. The hereditary deficiency of G6PD or glucose 6-phosphate dehydrogenase activity. G6PD reduces the nicotinamide adenine into NADPH. Nicotinamide adenine diphosphate into NADPH while oxidizing glucose 6-phosphate. So this reduced form provides reducing equivalent needed for conversion of oxidized glutathione to reduced glutathione. This reduced glutathione protects against oxidant injury by catalyzing the breakdown of compounds such as H2O into water. The common drugs and chemicals which causes hemolysis or injury are anti-malarial drugs, sulfonamides, nitrofurantoins, nalidixic acid, acetaminophen, acetyl salicylic acids, chloraphenicol. The triggers for hemolysis infection, viral hepatitis, pneumonia, typhoid, pneumocytosis. The food which causes hemolysis is fava beans. Laboratory findings: complete blood count, a peripheral blood smear may show signs of hemolysis such as schistocytes. White cells, hens bodies, these are the dark inclusions within the red cell. You can see these are the dark inclusion within the red cells and stained with crystal violet dye. There is reticulocytosis, bilirubin level is increased, serum aminotransferase, lactate dehydrogenase are also increased. NADPH protection fluorescent test and G6PD assay should be done for the diagnosis. Now hemoglobinopathy is sickle cell anemia. This one is the qualitative defect of hemoglobin. Defect in the quality of hemoglobin, not the quantity. This sickle cell disease is an autosomal recessive genetic disorder. This is actually an umbrella term used for all mutation in the beta globin gene that present in the same clinical syndrome. Number 1, heterozygous state for hemoglobin S, sickle cell trait. Homozygous state for hemoglobin sickle cell anemia. This one is double S. Double heterozygous state, sickle beta thalassemia. In the sickle cell trait, a benign heterozygous state of hemoglobin S in which only one abnormal gene is inherited, and the patient is usually asymptomatic unless develops hypoxia. Second thing is sickle cell anemia. Here, an abnormal copy of hemoglobin gene is inherited from each parent. SS. It is a severe disorder associated with different clinical manifestations, and the life expectancy here is decreased. The pathogenesis, the basic molecular defect or lesion is in the single point mutation, which involves one amino acid out of 146 of hemoglobin molecule. or the point mutation is at the 6th codon of the beta globin that leads to replacement of a glutamate residue with a valine residue. Only replacement. Mechanism of sickling. Oxygen tension when less than 40 millimeter of mercury for 2 to 4 minutes. During hypoxia, hemoglobin S molecule undergo polymerization. Initially, red cell cytosol convert to form a freely flowing liquid to a viscous gel as hemoglobin S aggregates. With continuous deoxygenated state, aggregated hemoglobin S molecule assembled into long needle-like fibers within the red cell and producing an elongated crescent shape or sickle-shaped RBCs, and this process is called as sickling. This one is the sickled RBC, sickle-shaped. Okay, beta. Clinical presentation in sickle cell disease: vaso-occlusion or blood vessel occlusion, leading to ischemia, acute systemic painful vaso-occlusion crisis. Second thing here is endothelial dysfunction. Third thing is sterile inflammation. These all are hallmarks of sickle cell diseases. Chronic anemia, aplastic crisis, osteonecrosis, osteomyelitis, dactylitis, leg ulcers, stroke, proliferative retinopathy, chronic pain syndrome, acute chest syndrome, restrictive lung disease, increased susceptibility to infections, chronic renal insufficiency, priapism, eclampsia, viral hepatitis, liver failure. These all may be the clinical presentation here, but the most common is the acute pain syndrome. Laboratory findings: complete blood picture reveals sickle red cells, reticulocytosis, and target cells. Oval jolly bodies in the red cells. Bone marrow is hyperplastic. Sickling test by metabisulfate. It is used to detect the sickling RBCs. Hemoglobin electrophoresis. Hemoglobin AS profile detect hemoglobin A 60% and S 40%, and hemoglobin SS profile. Hemoglobin S is 95% and fetal hemoglobin 5%. Adult hemoglobin is 0. X-rays will also show the frequent appearance on X-rays and prominent cheekbones. The megaloblastic anemia or macrocytic anemia is defined by large abnormally appearing precursors or megaloblasts in the bone marrow, resulting from inhibition of DNA synthesis during red cell production. When DNA synthesis is impaired, the cell cycle cannot progress to form G2 mitosis stage, leading to the continuous cell growth but without division. So resulting in the not microcytosis but macrocytosis. I'm sorry, this is my mistake. Macrocytosis. Causes are vitamin B12 deficiency. Number 1. Either decrease intake, inadequate diet or vegetarianism, or impaired absorption due to intrinsic factor deficiency in pernicious anemia or gastrectomy. Malabsorption state in screw or giardia lymphia infestation, diffuse intestinal disease due to lymphoma or systemic sclerosis. Ileal resection, ileitis, bacterial overgrowth in the blind. These all cause impaired absorption of vitamin B12, leading to the deficiency of vitamin B12. Folic acid deficiency due to increased intake or either resulting from inadequate diet, alcoholism, or infancy. Impaired absorption and malabsorption state, increased loss in hemodialysis, requirement is increased in pregnancy and infancy, and impaired utilization when using folic acid and antagonist drug. or unresponsive to the vitamin B12 or folic acid therapy in the presence of metabolic inhibitors of DNA synthesis or folate metabolism. The methotrexate drug when used causing unresponsive to vitamin B12 or folic acid therapy. Pathophysiology here is the common feature in megaloblastosis is the defect in the DNA synthesis in the rapidly dividing cells. To a lesser extent, RNA and protein synthesis are also impaired. Therefore, unbalanced cell proliferation and impaired cell division occurs as a result of arrested nuclear maturation. In bone marrow, more mature erythroid precursors are destroyed prior to entering in the peripheral blood. This is intramedullary hemolysis. Vitamin B12 and folic acids both are coenzymes. These are required for the synthesis of thymine, one of 4 bases of DNA. So the deficiency of vitamins or impairment in their metabolism results in the defective nuclear maturation due to the deranged or inadequate DNA synthesis and causing the delay or log in the cell division. Clinical presentation, it could be asymptomatic to severe anemia, weakness, cardiopulmonary impairment. Intramedullary hemolysis causing lemon color complexion. Gastrointestinal symptoms, loss of appetite, weight loss, nausea, constipation. Mental changes ranges from personality changes to psychosis. Beta bull, please. Ibra bull, wait, please. Let me finish the lecture. Peripheral neuropathy, numbness, pain, tingling, burning in the head and feet, loss of sensation. Unsteady gait and loss of balance occur in the subacute combined spinal cord degeneration in the later stages. The neurological impairment with no anemia. Neurological symptoms ranges from mild to severe. Physical signs, mild anemia, pale, weakness, severe anemia causing dyspnea, tachycardia, and cardiopulmonary distress, anemia with intramedullary hemolysis, increased direct bilirubin level causing cardiovascular infection. Glossitis, smooth and loss of papilla associated with cobalamin deficiency. The dermatological signs or skin involvement increase melanin synthesis causing hyperpigmentation of the skin and abnormal pigmentation of hair. Broad spectrum mental changes from feeling ability up to the psychosis. Morphology or clinical, laboratory picture. Complete blood count and peripheral blood smear showing hemoglobin is low. MCV elevated, MCH elevated, MCH reduced. RBCs macrocytic, oval jolly bodies are present, macro-ovelocytic, lacks the central pallor, anisocytosis, and poikilocytosis. Reticulocyte count is low, normoblasts may see. WBC, TLC count is low. Neutrophils are larger than normal, and the macropolymorph nuclear and hypersegmented. 5 or more lobes are here. You can see the 5 lobe size of RBC and size of this neutrophil. Hypersegmented neutrophil. 1. Platelets are reduced moderately. The lactate dehydrogenase, indirect bilirubin, iron ferritin assay. Test for cobalamin deficiency, serum cobalamin and Schilling test or protein bound absorption test. Test for folate deficiency, red blood cell folate which is better than serum folate. In the bone marrow aspiration and cytology. Biopsy. Bone marrow shows hypercellularity, megaloblastic changes at all the stages of erythroid development. Megaloblast, these are large and deeply basophilic cytoplasm, prominent nucleoli, fine nuclear chromatin pattern. Nuclear to cytoplasmic asynchrony. Megakaryocytes, these are giant multilobate nuclei, marrow hyperplasia, marrow iron with Persian blue staining. There is increase in the number and size of iron granules in erythroid precursors. Thank you so much, beta. Any question?